Hello, everyone. Welcome to the SBC Working Group's virtual forum lightning talk session on malaria SBC at the community level. My name is April Monroe, and I'm based at the Johns Hopkins Center for Communication Programs, and I'll be your moderator for today. I'm also joined by Emi Abihara, our Zoom expert, as well as Miriam Nabukenya Wamala, who will be providing closing remarks at the end of our session. As before, slides in English, French, and Portuguese are available in the link on this slide. Today we have presentations in English, French, and Portuguese. Emmy will be sharing her screen with the lightning slides in the language of the speaker, so please find your language-specific deck to follow along. Once again, don't forget to select a language, English, French, or Portuguese, in the interpretation button at the bottom of your Zoom window. Great, and I think we can go to the next slide. So today's 4 lightning talk presentations fall under the topic of malaria SBC at the community level. Many of today's presentations focus on the unique role of malaria SBC can play in vector control. Each presentation will be 5 minutes, followed by a brief 3-minute question and answer. So please type your questions in the chat, and I will ask the speakers when they finish. As speakers, as you may imagine from the lightning talk name, these will be quick presentations. We want to make sure that we have time for all of these great presentations. So I will have a timer here to make sure that we're sticking to time and that we have time to do all of the wonderful content that we want to cover. I'll warn you once you've reached your allotted 5 minutes. And if we do go over the 5 minutes, that'll reduce the question and answer time. So please stick to time. With that, we're going to get started with some exciting lightning talks. So first, I would like to introduce Mark. And Mark, can you tell us how to pronounce your last name? Apologies for the question, but want to make sure we get it right.
Yeah, it's Luakatari.
Luakatari. Thank you so much. All right, welcome so much. Welcome, and over to you.
Okay, thank you. Briefly, I'll talk about the impact of community level SBC interventions, specifically for malaria. And as you all know, progress has been made with regards to the control of malaria, but still it remains a public health concern, particularly in Tanzania, with more than 5 million cases which are reported annually. So through SBC, an integrated SBC platform called Naweza, which is under USAID to Olagafia, which is an integrated health SBC program that uses a life stage approach to focus or to address health concerns with regards to priority behaviors during the course of pregnancy and childbirth, but also caregiving for children under 5. And we use the adult SBC platform, which is Naweza, meaning I can in Swahili. And this is for those people or women who are above the age of 18 years, together with their support systems. So with this SBC platform called Naweza, we were able to reach and engage priority audiences or target audiences through different interventions. We used national level media or interventions like the mass media, like radio, but also we had community radio engagement where we aired radio spots, but also we had anchor show episodes which focus on specific behaviors and to address their concerns. But also we used social media for those who were able to access mobile phone technologies. But we also used print media as well through billboards, posters, brochures that were distributed at the community level and facility level. With regards to community-specific activities, we focused on mother meetup events. These are events that gather new mothers as well as experienced mothers together with facility workers who address concerns with regards to motherhood, but also caregiving for children under 5 years. We also used public spot announcements as a reminder for people regarding to use services that are available to them in the community. But we also used community theaters, which draw a lot of a lot of crowds to see edutainment interventions like dramas depicting experiences with different behaviors, health behaviors. But we also had IPC group dialogue sessions where we draw partners of pregnant women, but also caregivers, and also elders and in-laws. Here we engage them in groups of 10 people where we explain the importance of adopting specific behaviors for malaria, but also ANC attendance and the IPT uptake. So all these are addressed in those group dialogues. But also we had timed household visits during the first year of postpartum, where pregnant women who give birth are also followed up after giving birth, so that we can address their needs with regards to malaria or care seeking for children who have been born, so that they're not left behind. And all these we're focusing on malaria behaviors, but also behaviors which prompt or promote the uptake of malaria behaviors. But also during the course of the project, we're able to collect data throughout the project's life cycle, so we could track progress of these approaches, and we can adapt accordingly, because we try to, or we actually focused on adaptive management as our leading guide for adapting our programs. But also, with these initiatives, what results we're able to see through our community activity interventions, we were able to reach 1.8 million people. These are we were able to reach 1.8 million, which were including pregnant women, their partners, but also caregivers of children under 5 years through our community media activities. But also we were able to reach over 500,000 caregivers of under 5s through these timed household visits. As I said before, we reach them through the stages of pregnancy up to childbirth, but also after facility delivery and caregiving stage. But also we're able to reach over 150,000 pregnant women and their partners through these small group dialogue sessions. And this was actually very significant, because the partners were also a driver with regards to male involvement initiatives. What we were able to see within our 29 enhanced districts, these are districts where there is, I can say, as where we can say that we have more or intensified interventions as compared to non-enhanced districts, which only get maybe mass media interventions. So what we're able to say is that pregnant women were 4 times more likely to feel confident in the ability to prevent malaria during pregnancy. As we all know, self-efficacy is a key behavior determinant when it comes to the uptake of behaviors. So this was actually very significant. Another area that we saw improvement or impact was caregivers of under 5 children were 4 times more likely to believe that they can seek prompt care at the health facility for a child with a fever, because during our formative research activities, when we were developing interventions for the project, we kept on hearing that women or caregivers don't seek prompt care for their child when they have a fever. They wait for at least another day or 2 days to seek care, and because they believe they can manage the symptoms themselves. So this was a very big impact. But also we saw that there was positive attitude towards.
You're a little bit past 6 minutes, so
okay, but I'm done. Yeah, so I was also,
so much.
I'm winding up. So what we also saw is that people had positive attitude towards malaria treatment. They believe that ACT is the best course of treatment, because in the beginning, people used to rely on other modes of treatment for malaria, like traditional medicines and other kinds of medication. But with this, we saw it's a very big improvement. I would like to say thank you for listening, and over to you, April.
Wonderful. Excellent presentation, and really impressive that you were able to reach so many people so effectively. And just, as someone who has a young child myself, I just imagine those timed visits could be really helpful to have that ongoing support. So thank you for sharing that great work. And it looks like we have a couple of questions in the chat. So Cynthia would like for you to share how the NOESA SBC platform works. Could you say a little bit more about that?
Thank you. So the NOESA platform is an SBC platform which has, I can say, a bucket or a basket of behaviors that focus a woman's journey in the health, let's say the health journey. For example, we believe women, when during pregnancy, they have their health needs. For example, they need to go through ANC, they need to go through IPT uptake, they need to go through HIV testing, and if they're found positive, they need to start treatment. But also, we believe that they need to know where they can have the delivery for the baby when the time comes, which is facility. But also we need to promote that if they give birth, that they should consider family planning for at least 2 years. But also after delivery, they should consider the health of their baby and themselves as well. So the NOESA platform is like it's like it's not a campaign, but it's a concoction of campaigns within its platform. So it's where we address these needs for our adults and for our audiences rather, so that they can get the right treatment. And it's all demand creation and linking to service uptake, because we have very many activities which are related to this platform. But we also have a separate platform which is for youth specifically and their needs, for their health needs, so that they don't interrelate whatsoever, because they're different needs compared to the NOESA needs. And what I can say is it has been very, very effective, because we use multiple interventions to reach our people through this platform. We adopt like I said at the beginning, we use radio messaging, we use timed household visits using our community health workers, community volunteers who conduct these sessions with our audiences. So it has been very effective with reaching with our audiences through this. But we also have done community events or media activities which engage our audiences through these life stages. I don't know if I've been clear on that.
Yeah, excellent. Thanks so much for that explanation, Mark. And it looks like there's a lot of interest in your presentation. I see some other questions in the chat. Just to make sure we have time to get to the other presentations, we're going to move forward. But if you have a few moments to take a look at the chat and maybe to respond there, that would be great. I see some questions on how you reached so many people, estimates of numbers reached through, how you estimated numbers reached through media activities, questions around literacy. So will be great if you can address some of those in the chat. And thank you once again for a great presentation. All right, wonderful. So thanks once again to Mark for a wonderful presentation. And next up, we have Temitope Ogunbi of CCP Breakthrough Action, Nigeria. The floor is yours, Tope.
Right, thank you, April. I'm going to be talking us through SBC for integrated delivery of ITN and SMC during the COVID-19 pandemic in Zamfara state of Nigeria. I mean, as we all know, COVID-19 caused significant additional malaria deaths globally, according to the World Malaria Report 2020. And in addition to this, the COVID-19 pandemic also really disrupted services in several sectors. And the health sector was one of those sectors that was mostly affected. Within the peak of the COVID-19 lockdown in Nigeria, delivering life-saving interventions, services were really delayed, including crucial interventions like seasonal malaria chemoprevention and distribution of insecticide-treated nets. Of course, at the time, mass distribution of any nature also carried the significant risk of transmitting the COVID-19 to both the campaign staff and households. So to prevent further delays, and because interventions like the seasonal malaria chemo prevention campaigns are time bound, normally happens within the peak of the rainy season from July through to October. A decision had to quickly be taken by implementing partners to integrate both campaigns. I mean, this was the first that we would ever do in the country. The campaigns typically happen separately. We have the seasonal malaria chemo prevention campaigns happening at the peak period, while the ITN campaigns could happen anytime within the year. So the decision to integrate had implementing partners needing to develop a strategy that would work for such an integration within a short period of time and without any historical experience to draw from. I mean, integrating other campaigns or other health programs are well documented. However, little or nothing was known about successful integration of SMC and ITN campaigns. So to implement the campaign, PMI implementing partners, Breakthrough Action Nigeria, Global Health Supply Chain Management came together to brainstorm and finally agreed to adopt a modified hybrid commodity distribution and communication strategy for the campaign. So some of the changes that happened, for instance, during household enumeration, where enumerators go from house to house to issue net cards, this stage of the campaign was taken to also administer SMC medicines to eligible children who were aged 3 to 5 months. Subsequently, the net cards that were issued during the enumeration were redeemed for nets through fixed distribution points as well as mobile distribution points, especially for households that were hard to reach. So demand creation for this integrated campaign utilized several approaches, most of them multi-channel approaches where advocacy was used to ensure political commitment. And like you are aware, during the peak of the COVID-19 pandemic, most state governments apportioned more of their health budgets to tackle the COVID-19 pandemic. So there was little or nothing left for other health program areas. So COVID was prioritized, malaria and other diseases were deprioritized. At the community level, advocacy was also necessary to carry the community along, knowing fully well that people were skeptical about gathering in large crowds and all of the restrictions were in place. Advocacy was also used to ensure that the media, which was one of the most effective channels of communication at the time, we used advocacy to also ensure that the media was carried along and supported the SBC component messaging for the campaign. So messages were delivered by locally recruited town announcers who followed all of the COVID-19 infection prevention restrictions, like distancing themselves from announcements when they are in communities. They were given wipes, disinfectant wipes to disinfect their megaphones as they made announcements and all of that. Then, of course, radio and TV was also a medium that was used to pass on messages. Messages developed, of course, emphasized the importance of malaria prevention, was also used to correct myths and misconceptions that came up during the campaign. Prompt care seeking for COVID, of course, was promoted, and most importantly, a rumor management process was also in place for the campaign. So from the community level to the ward level and to the state level, this mechanism was put in place to ensure that rumors were promptly tackled and feedback was given where they occurred. So for looking at the results, the integration of these campaigns was highly successful. The end process survey and the lot quality assurance sampling that was done to look at the output indicators for the campaign showed that 2.9 million nets reached beneficiaries, accounting for a 96% uptake during the campaign. Net uptake was high, and then the target of 80% net utilization was also for different target populations was mostly surpassed, as we can see. The coverage for SMC, as delivery of the medicines to eligible children, achieved a 91% coverage, which was quite impressive given the pandemic nature of the time when it was implemented. Of course, the effective rumor management was helpful in curbing the spread of rumors and misinformation that came up during that period. Advocacy efforts led to government contributions in the tune of over $354,000. This was significant because, I mean, like I said earlier, priority was not given to malaria interventions at the time. And also importantly to note is that the COVID-19 infection life count in Zamfara State at the time did not spike during the campaign. I mean, you will know that with all of the restrictions and the fact that there were still distribution points for people to go redeem their nets, all of this did not increase the COVID-19 infection life count. So I'll conclude by saying that the integrated campaign in Zamfara, the experience shows how innovations in commodity distribution and SBC approaches tailored for integrated campaigns in the pandemic context can contribute to successful delivery and uptake of malaria prevention interventions and the maintenance of healthy malaria behaviors. Thank you.
Great, thank you so much, Tope, and wonderful presentation. It looks like there is a question in the chat about cost. So I see you mentioned raising the $354,000 to support campaign activities through advocacy efforts. Can you say anything else about the costs required by the intervention?
Oh, yeah. So, I mean, the total contribution from the government of the state was about 20% of the total cost of both the ITN and the SMC campaign. When you look at procurement of the nets, payment of distribution personnel, and all other costs that are associated with both campaigns. So their contribution was about 20% of the campaign. Now, there's a cost comparative analysis that is still underway. When we get results of that, I'm sure in subsequent conferences or meetings like this, we will be able to provide information around how cost-effective an integrated campaign vis-a-vis campaigns that are done in silos will be. Yeah.
Great, wonderful. And I see a nice question from Sean as well in the chat. I think for the purposes of time, we'll move on to the next presentation, but if you can take a quick look at that and respond in the chat, that would be wonderful. And I see maybe some more questions coming in as well. So thank you once again, Tope, for a wonderful presentation.
Thank you, April. Great.
Our next speaker is Elio Rogerio Martinez from FHI 360. Elio will be presenting in Portuguese. So once again, please make sure you have interpretation turned on at the bottom of your screen. Over to you, Elio.
Boa tarde.
Good afternoon. Thank you very much, everyone, for the invitation. As mentioned, I am Elio, and I'm here representing FHI. Can you see my screen? Let me check here.
Sim. Perguntava se
So I was asking if you can see my screen?
Yes, we can see it. Thank you, Elio.
tá. Obrigado.
Perfect. Thank you very much. So I can start my presentation. I apologize. I'm trying to hide this excessive information on my screen, but let's just move forward. So FHI in Mozambique implemented an intervention for 5 years. It's integrated malaria program that aimed at offering information to the community about ways to prevent malaria and improve its effectiveness in the process of prevention. This is information about this assessment that we did after 5 years of work. Based on conversations that we had with people in the community, the mobilization of influencers inside the communities, among others. Also dialogues with sanitation units when it comes to ways of preventing malaria. There were also household visits as well as radio programs. So I would say that the introductory notes by Mark could also be here. Malaria in Mozambique is among the main public health issues. Until June last year, there were 6 million cases in a country that has around 30 million residents. That gives you an idea of the severity of the problem in terms of public health. It is still the main cause of hospitalization, and it is among the main causes of death in the population of Mozambique. So for this study, for this assessment, better said, we did some interviews, qualitative, community level interviews, very deep interviews with the community. The emergent themes, there are two that we'd like to highlight among other themes that were also brought up. But one of them is that it is still complicated to set up the bed nets in the village homes, the way that the houses are built in these communities. And also there's still the habit of reusing the nets in other situations which are not very connected to malaria prevention, in yards, in balconies. It's one of the most common things to protect yards, to protect herbs and stuff like that. And these habits are replicated. They are learned one from each other. Neighbors learn from each other. These are habits that are very common for them to be replicated among neighbors. One of the things we've noticed is that the barriers to the net use, they go beyond the lack of knowledge or lack of motivation. The current net designs, they are difficult to hang sometimes. There are several types of nets, but here we're talking about those that have 6 points to hang on the ceiling. So they're not easy to use. There's also some reports of people having rashes caused by the insecticide of the nets. That also leads to people easily starting to reject the nets. In terms of lessons learned, we think that the available model of net is not yet too well adjusted to the conditions that people have in the villages. The actual conditions of the rooms, the beds themselves. Sometimes it's not even a bed. Sometimes they sleep on mats. So placing the nets doesn't really work very effectively. And it would be interesting to rehearse projects, to identify better ways, more successful ways to use these nets in terms of different models and adaptations that can be done, or even nets that could be used in different situations. This idea that they are designed for a single purpose, let's say for a conventional bed, there is this idea. But there are also situations of people that easily notice that the use of the net and also reported a continuous use throughout the year. So these are also experiences that can be useful to get replicated for other members in the community. A final comment is that the reusing of the nets, already considering WHO guidelines and the PMI technical guidance against malaria, we also found reports of this reuse of nets, but not as much. It was more common what I mentioned previously, which was using the net for other purposes other than preventing malaria. So to wrap up, we still have challenges to tackle for the change in behavior when it comes to fighting against malaria in Mozambique. And thank you very much for your attention.
Great. Thank you so much, Elio, for the wonderful presentation. And I see we have a couple of questions in the chat, and I think there's one in French. I think I understand what it's asking, but if I get this incorrect, please let me know. I think the question is around if the house really isn't conducive to hanging the net, how do you expect people to use them? And I think this gets at the issue of structural barriers and how we have a broader lens for SBC now. So it's not just about behavior, but also about creating that conducive environment for people to practice those behaviors. So based on your work, Elio, what would be your recommendations to the National Malaria Control Program or to other partners or donors about what could be done to make nets easier to use in these communities?
Obrigado.
Thank you
Exatamente.
for your question. That is precisely what I didn't go deep into that specific question. We already have the evidence that the nets, I'm sorry, we lost Helio. Helio seems to have lost audio.
Okay.
Desculpem, comecei a falar ainda com o microfone.
He is back. I'm sorry, my microphone was muted. Helio, we lost Helio again. No audio for Helio still. We apologize for that. He is back. I'm sorry, I'm having problems with my microphone. It is disconnecting by itself. I apologize for that. I think I can speak now. Okay, so I was saying that we already have this knowledge that the nets cannot be all the same type for the communities. It is needed for us to go to this next step of assessing the conditions of each different community in which we're going to intervene and see, in fact, how we can adapt the nets so that, in fact, they become more usable, they have more acceptance, and they are effective in their purpose. That is the next step, because until now, what we have seen is that we have nets that are all the same type. It's a batch that we receive, and that is what's going to be distributed to the communities, regardless of the condition that they have in their households. So I believe that that would be my answer to the question, if I understood the question well.
Yeah, thank you, Elio. And I think we'll have one more quick question that I see from Hannah in the chat, noting that at least based on the most recent MIS survey, that net use seems to be quite high. And so wondering how much these barriers are actually impacting use. Could you speak to that? And Hannah, if you want to add anything to that, please feel free.
Exatamente. Esses problemas.
Exactly. These problems are, in fact, temporary. or a transition, and it's a high indicator. But this situation has been made people immediately abandon the net. And there's a lack of understanding that it's a transition that's temporary, that they can leave the net on a outdoor, and that would then reduce the rash, reduce the irritation, and that can also contribute to this rejection. Yes.
Thanks, Elio. There may be some additional questions for you in the chat. So I think for the purposes of time, we're going to move forward, but please feel free to continue the discussion in the chat. I think these are some really important comments and questions to discuss. All right, great. So thank you once again. Great. Thank you once again.
Thank you very much.
All right, our next speaker will be Dr. Fanche Awokwo of the Malaria Consortium. And Dr. Awokwo will be presenting in French. So over to you.
Merci beaucoup, modératrice.
Thank you very much. Hello, everyone. Hello to all the participants of this forum. It is a pleasure to me to show you the outcomes of a research that we did in the use of the role model approach to monitor the administration of sulfadine pyrimethamine to children. We are in Togo, next to Ghana, and we have a population of about 9 million inhabitants. We started working in 3 different regions with the support of 3 partners and Malaria Consortium. So we started this activity. So we have been a couple of issues. So the refusal of sulfadoxine pyridine to children, and other elements that are not making it easy for the treatment to work in regions where there is a lot of children. The problem we have that in a couple of households, we don't have that problem. We work on the role model approach, where we identify the behaviors we want in a community. We work in the Pakala district in Togo, where we have the refusal rate in 2020 was 5%, which is the highest percentage of the country. This approach helps us identify local solutions that we can reply or use again without a big intervention from the exterior. And this is what we use during a behavioral change based on local solutions. We did it through 15 interviews that we did in 3 villages. And this helped us identify the key behaviors that we wanted to promote in these villages, in these communities. And these behaviors were promoted by volunteers in the community in collaboration with the program of the fight against paludism in Togo, of malaria in Togo. We have analyzed the situation and we used another approach, the qualitative method, with a WHO methodology. And we tried to see which were the activities, and we started doing some research. We have more than 98% of the household that only used water to take this medicine instead of other things that were used somewhere else. And there are 5 key behaviors: avoid violence against children, presence of the father, the fact of speaking to the child so that he can accept the medicine, and not forgetting to give the children the other doses of the medicine. And we had more than 98% of the households that believe that the drugs are effective in protecting young children from malaria. So for the lessons learned, there are misconceptions on malaria. And we wanted to also understand what were the issues so that our messages would be adapted, and wanted to know how our message could be more accepted. This research helped us prepare the campaign in 2022 through the promotion of these key behaviors in other districts of the country, and this helped us improve the implementation of this intervention. Thank you very much for your attention.
Great. Thank you so much, Dr. Wokwo. It looks like we have a couple of questions in the chat. So one is whether you used any mass communication, so including local radio as part of this.
Lors de l'étude, nous n'avons pas utilisé de
No,
médias.
during our research, we did not use mass communication or media, but we used interpersonal communication. So that's what we used.
Great, and it looks like you answered one of the other questions, which was about which approach you did use. So it sounds like really using a lot of interpersonal communication, which is great. And then also a question on sample size. So for the in-depth interviews, if that was sufficient to get the information that you were hoping for.
Oui, pour les entretiens. Oui, OK.
Yes. Yes, thank you. So for the in-depth interviews, we used 135 participants. And for each group discussion,
De COVID-19 qui prévalait.
Because of the pandemic, we only had 8 participants per group. And we did for the mothers, 2, 3 for the fathers. And in total, we had 135 participants for the whole activity. But for the research, the qualitative study, we used another method, and we had more than 400 people. in the participation of this qualitative study.